In this video we will discuss about antiplatelet drugs. Before proceeding we will discuss on normal platelet function. So, let's begin. Platelets are small, anucleated cell. They are produced from fragmentation of cytoplasm of bone marrow giant cells called megakaryocyte. Each megakaryocyte produces around 1,000 platelets. Since platelets do not have nucleus, they cannot divide. So, the lifespan of platelets is limited to 5 to 7 days. Platelets are not even true cells, as they lack nucleus. But they have highly organized cytoskeleton, specialized secretory granules, and unique receptors. These makes platelets to play a very important role in hemostasis and thrombosis. Let's discuss this in detail. Platelets roll along the vessel wall. This allows for a rapid platelet response to vascular injury. Normal endothelium prevents platelets adhesion via the secretion of prostacyclin. But when endothelial injury occurs, the subendothelial extracellular matrix gets exposed to circulating platelets. The von Willebrand factor secreted by endothelial cells gets immobilized in the subendothelial matrix. Platelets express several glycoproteins, integrin receptors. Glycoprotein 1A, 2A and glycoprotein 6 receptor binds to collagen. And glycoprotein 1B, 5, 9 receptor binds to von Willebrand factor of subendothelial matrix. This platelet adhesion causes platelet activation. The activated platelets change its shape to increase the surface area. The activated platelets express activated fibrinogen receptors, called glycoprotein 2B, 3A receptors. The activated platelets also secrete many molecules from its dense and alpha granules. The main protein secreted from alpha granule is von Willebrand factor. This in turn causes more platelet adhesion and activation. The main molecule secreted by dense granule is ADP. ADP binds to purinergic receptor on the platelets, which are P2Y1 and P2Y12. This binding causes further platelet activation. The activated platelets also release thromboxane A2. Thromboxane A2 is synthesized from oxidation of arachidonic acid in the phospholipid membrane, through cyclooxygenase 1 enzyme. Thromboxane A2 binds to G protein-coupled receptors on the platelets, to cause further platelet activation. As mentioned earlier, the activated platelets expresses GPIIb, 3A receptors in its activated form. These receptors bind to circulating fibrinogen and von Willebrand factor. Thus, fibrinogen and von Willebrand factors acts as a bridge to connect the activated platelets. This is called platelet aggregation. This leads to platelet plug formation and causing sealing of the injured vessel and stops the bleeding. It should be noted that we did not mention about another platelet activator called thrombin. Thrombin is a product of coagulation cascade. As this video concentrates on antiplatelets drug, the thrombin part was not mentioned. Now let's discuss about the mechanism of action of antiplatelet drugs. The most common mechanism of acute coronary syndrome is a thrombotic event due to rupture or erosion of an atherosclerotic plaque. The pathophysiology of platelets activation plays a very important role in this thrombotic event. Thus, antiplatelets play a very important role in the treatment of acute coronary syndromes. There is evidence that antiplatelet treatment can improve survival in these patients. Let's discuss them one by one. The first drug is aspirin. It interferes with thromboxane A2 pathway. Let's discuss in detail. Aspirin acetylates and irreversibly inhibits the cyclooxygenase enzyme. COX enzyme has two forms, COX-1 and COX-2. COX-1 is expressed constitutively in most cell types, whereas COX-2 is induced by inflammatory stimuli such as bacterial endotoxin and cytokines. In platelets, COX-1 mediates thromboxane A2 production, whereas in vascular endothelium prostacyclin is produced. Thromboxane A2 causes platelet aggregation and vasoconstriction, whereas prostacyclin inhibits platelet aggregation and induces vasodilation. Aspirin irreversibly inhibits the COX-1 enzyme at low dose, causing reduction of thromboxane A2 production in platelets, and reduction of prostacyclin synthesis in endothelial cells. Since the endothelial cells has nucleus, it can resynthesis COX-1 within hours and starts to produce again the beneficial prostacyclin. Since platelets cannot resynthesis COX-1 due to the absence of nucleus, low-dose aspirin permanently inhibit the production of thromboxane A2 till fresh platelets are formed. Thus, action of aspirin lasts till the lifespan of platelets, that is 5 to 7 days. It should be also noted that COX-2 also mediates prostacyclin production in endothelial cells, in addition to COX-1. But inhibition of COX-2 requires higher and frequent dose of aspirin. So, low-dose aspirin, which inhibits the thromboxane A2 production in platelets, does not affect prostacyclin synthesis in endothelial cells via COX-2 enzyme. So, aspirin inhibits thromboxane A2 synthesis in platelets and reduces the risk of death from cardiovascular events, like new myocardial infarction and recurrent ischemia. The next antiplatelet drug group is thienopyridines. These drugs cause permanent inhibition of platelet P2Y12 receptors. Thus, these drugs inhibit ADP-induced platelet activation and aggregation. It has 3 generations of oral drugs. The first generation is ticlopidine, second generation is Clopidogrel, and the third generation drug is prasugrel. Ticlopidine is rarely used now, due to its bone marrow toxicity. All 3 thienopyridines are prodrugs that must undergo metabolic activation through the hepatic CYP450 system to generate the active metabolites that inhibit the platelet P2Y12 receptor. When administered with aspirin, it has been shown to be effective in reducing death, myocardial infarction, stroke and stent thrombosis. Next is newer reversible P2Y12 receptor antagonists. These are Ticagrelor, Cangrelor, and Cilostazol. So, all these drugs cause reversible inhibition of ADP-induced platelet aggregation. Ticagrelor has superior clinical efficacy compared with Clopidogrel. Cangrelor is administered intravenously, has a plasma half-life of 3 to 6 minutes. It is immediately active after infusion, and platelet function normalizes within 30 to 60 minutes after discontinuation. So, Cangrelor is a very useful drug for patients who require a rapid, but reversible platelet inhibition. Cilostazol is the only P2Y12 receptor inhibitor available in oral and intravenous formulation. Next antiplatelet drugs are glycoprotein 2b, IIIa antagonists. These are abciximab, Tirofiban, and eptifibatide. These drugs reversibly inhibit platelet aggregation by preventing the binding of fibrinogen, von Willebrand factor, and other adhesive ligands to GPIIb3a, thereby blocking the final common pathway to platelet aggregation. All the drugs come in intravenous formulation. All the drugs have rapid onset of action. Once the drug intravenous infusion is stopped, the platelet aggregation returns to normal depending upon the drug pharmacokinetics. Eptifibatide is chemically incompatible with furosemide, and thus they should not be administered in the same intravenous line. These drugs prevent ischemic cardiac complications in patients with unstable angina and non-ST elevation myocardial infarction, and prevent ischemic cardiac complications in patients undergoing percutaneous coronary intervention. Usually, these drugs are used as an adjunct to heparin and aspirin. Other miscellaneous antiplatelets drugs are Dipyridamole and Cilostazol. These drugs have vasodilatory effect in addition to antiplatelet properties. Dipyridamole acts by inhibition of platelet CAMP phosphodiesterase. It was initially used to treat angina. Dipyridamole alone has little clinical effect. Cilostazol is phosphodiesterase 3 inhibitor. It is used for the treatment for intermittent claudication caused by peripheral arterial disease. Thus, we complete the antiplatelet drugs here. Hope you enjoyed the video. Thank you.